Good afternoon and welcome to today's webinar, COVID-19, Vulnerable Populations and Palliative Care, Call for Social Justice, brought to you by the Network for Public Health Law. I'm Charles Strong, the Senior Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. This is the final webinar of a three-part series co-sponsored by the Network for Public Health Law, the New York State Bar Association Health Law Section, New York City Bar Association, Health Law, Science and Law, Bioethical Issues, and Immigration and Nationality Law Committees, the University of Rochester Medical Center Finger Lakes Geriatric Education Center, and the Collaborative for Palliative Care. You can access the playbacks for the other webinars in this series on the network's website. We strongly encourage attendee participation and would love to hear from you, so feel free to submit your questions at any time during this webinar by using the Q&A tab on the right-hand side of the screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your questions. We will be addressing them during the Q&A session towards the end of today's event. Your moderator for today's webinar is Heather Hatcher. Ms. Hatcher is an Associate Counsel at New York City Health and Hospitals Corporation, where she serves as claims counsel helping to oversee the defense of medical malpractice actions against the system, and is a policy advisor on proposed legislation and quality initiatives. She is a member of the Delta Omega Honorary Society in Public Health. Hatcher is a member of the New York City Bar Association Science and the Law and Health Law Committees. She is admitted to practice in New York State, as well as before the Eastern and Southern Districts of New York Federal Courts and the U.S. Supreme Court. Heather will be leading us through the rest of today's webinar, so Heather, over to you.
Thank you, Charles. Thank you all for joining us at this last session of what has been a series on public and global health law and ethics across diverse systems, populations, and workforces, presented by the co-sponsoring organizations that were listed by Charles earlier. As the National Academy of Medicine has reminded us, the groups most at risk before a disaster are those that are most vulnerable during a disaster. And we can continue to see the truth of that statement as the world continues to grapple with the COVID-19 pandemic. We have also witnessed unlikely partnerships and cooperation between local and international governments, collaborations between historically competing private entities, and an outpouring of kindness and support by the general population for a stressed healthcare system and its frontline workers, essential workers in all industries, and for those who have continued to be disparately impacted by the COVID-19 pandemic and this disease. We are bearing witness now to a renewed zeal for justice and equity, in part reignited by this disparate impact of this pandemic on the most vulnerable of our society. At the outset of the pandemic, it was clear that populations at greatest risk for severe disease from this novel virus included some of the most vulnerable of our population, the elderly, those in congregate settings, and those with pre-existing comorbidities who had less consistent access to healthcare resources. We continue to identify and to seek redress for these issues. And I thank the panelists who have graciously agreed to participate today for providing additional insights as to how COVID-19 is impacting these populations and to make some recommendations for public health responses. Please note that more complete biographical information for each panelist appears on each of the slides. But I am pleased to introduce this afternoon's panelists. Beth Morrissey, who is a healthcare attorney and gerontological social work researcher and research fellow at Fordham University's Global Healthcare Innovation Management Center. Dr. Thomas Caprio, who is a professor of medicine, psychiatry, dentistry, nursing, and public health at the University of Rochester and chief medical officer for the University of Rochester Home Care and Hospice. Jeff Kagan-Trenchard, a lawyer with a career in public justice and welfare, who has received recognition for their work in the area of equal justice, child welfare law, and on behalf of LGBTQ asylum seekers, and Dr. Christopher Comfort, Chief Operating Officer at Calvary Hospital. Each of these panels will address the impact of this disease on our communities, including structural and human rights perspectives on health, vulnerability, and palliative care in COVID-19, legal reforms, public health strategies, human rights frameworks, and lessons from the front lines. The opinions and statements made are those of each individual panelist, and not necessarily those of the sponsoring organizations or the panelists' employers. Please, as we go forward, feel free to type questions throughout the presentations, as we will have time, hopefully, for questions and answer session at the end. Thank you. Mary Beth.
Thank you so much, Heather, and good afternoon to all of those who are with us this afternoon. I'm delighted to be kicking off the program with a lens on health, vulnerability, and palliative care in COVID-19. So this is the state of affairs that we are immersed in on July 9th, 2020. I guess you could describe it as a state of disequilibrium, chaos, as we bear witness to an unprecedented global pandemic, uncontrolled virus spread here in the U.S., and the devastating impacts of the pandemic, including the extent to which the pandemic has exposed systemic racism. Let me speak a little bit about my focus on what I'm calling the health, vulnerability, and palliative care triad. So these three things have very important relationships to each other. First, of course, health, as you know, is a fundamental human right, but it is also determined by political, social, economic, and environmental conditions that can threaten health and our health security. And what does health have to do with vulnerability? Well, vulnerability is also one of those social structural conditions that arises from underlying inequities, socioeconomic causes of injury, disease, and death, and in the language of my colleague Thomas Teo, forms of racializing or subhumanizing people, forms of social suffering. These are social problems outside the healthcare sector and delivery systems that, again, threaten not only our health security, but our very humanity. Now, Larry Gostin, whom we all know probably, an eminent public health law scholar, and his colleague Jonathan Mann recognized a number of years ago the relationship of the right to health to the full spectrum of human rights, and that is a mutual and interdependent relationship. In the context of this afternoon's program, I think the best example is probably that of the scarcity of water and the burden that such scarcity has imposed on the right to health of Indigenous peoples, and we'll talk more about that later. Finally, palliative care. Palliative care sits at the nexus of the right to health and human rights, supporting health and palliative care in that health spectrum, but also making it possible to create and sustain supportive environments. So now a few words about our history of inequities and disparities. It's important for us to be aware of the theoretical perspectives we're drawing on as we discuss racial and social justice and injustice. And here I highlight a few of those critical theories that I'm working with, particularly those of my colleagues in the American Psychological Association and their critiques of neoliberalism, Jeff Sugarman in Canada, Thomas Teo also in Canada. And once again, our colleague Larry Gostin and his theorizing about public health and human rights. He speaks about global health with justice, which I think is a very helpful frame for us today. And we can't overlook disabilities rights, which our colleague Dr. Joseph Finns has written extensively about. So turning to Joe Finns and a recent article he has written, he's talked about the comparison of the experience in the plague of Athens as described by Thucydides and the current experience of suffering and loss of nomos or law, rationalism in COVID-19. And really the description here of despair is a very poignant one and one with which I think we can resonate. Of course, in this 21st century, we've had experiences with other disasters, the Ebola crisis in West Africa, the 2003 SARS outbreak, influenzas, earthquakes, hurricanes, And of course, we cannot overlook the human contributions to climate change, including global inequalities. Once again, an example being the scarcity of water. And I recommend to you the beautifully written encyclical Laudato Si, Care of Our Common Home, by Pope Francis, which really looks at these issues very meaningfully. So you're all probably familiar with much of this data, so I won't spend a lot of time on it, but you see here that the numbers are quite disturbing, both in terms of the global cases and deaths and those in the U.S. We hit a milestone in the last couple of days, over 3 million confirmed cases here in the United States. And in New York, where I reside, we were the epicenter, but now things are under control, at least for the time being. Deaths in New York are about 32,000. But of course, we want to spend a lot of time today talking about the disproportionate impact upon minority populations and this issue of intersectionality. For example, when we're speaking about the nursing homes, the Black African-American nursing home residents who have been very detrimentally affected by the pandemic. Also, the American Indians and the indigenous populations, pregnant women and frontline workers, as well as persons incarcerated and immigrants. And I deeply apologize that we cannot afford just treatment to each of these groups today, but we hope that in future webinars we'll be able to explore these issues. So I'm going to share with you a couple of studies that have recently come out. One here has been done by the Levy Economics Institute at Bard College, showing the regressive effects of the pandemic and the way in which the pandemic has exacerbated pre-pandemic inequities and injustice. These researchers, using a health risk index as a function of poverty and percentage of minority population, showed that the incidence of risk is much higher in poorer communities. I had a hard time really identifying data on American Indians, Alaska Natives, and indigenous peoples, and I reached out to my colleague Joe Gahn at Harvard, who's again a colleague in the American Psychological Association, so he helped me out a bit. But in that middle bullet point, you'll see that if you use a prevalence lens, that Native Americans and indigenous peoples are disproportionately affected by the pandemic. And I'm quoting Joe here, Joe Gahn, on the historical trauma experience of our indigenous peoples here in the United States. In contrast to personal experiences of a traumatic nature, the concept of historical trauma calls attention to the complex, collective, cumulative, and intergenerational psychosocial impacts that resulted from the depredations of past colonial subjugation. I'm hoping that my colleague Jeff will talk more about that in a few minutes. Here's a study that just came out from the University of Albany on the disparities in New York. And here, once again, you see that non-Hispanic Blacks have higher rates of COVID-19 diagnosis, hospitalization, and death. Let me turn once again to the case example of the nursing home residents. I myself have served as past general counsel to a nursing home and do a lot of work in nursing homes, and also have lived through the experience of my grandmother being in a nursing home quite a number of years ago. So I think certainly both across the country and here in New York, we have borne witness to major system failures. You see here the number of deaths among nursing home residents and workers, 43% of the U.S. death total, which is quite staggering. Shortages of PPE, staffing shortages, which certainly contributed to neglect, failures in communicating with families, breakdowns in regulatory oversight, but let's not lose sight of the human faces and stories of the nursing home residents. Abandoned, improperly discharged, in some cases to homeless shelters, heightened risks of abuse and neglect, and conditions of confinement and isolation, really, in some cases, amounting to human rights violations. So in my limited time today, I'd like to spend a few minutes on legal reforms, public health strategies, and human rights frameworks to address some of these issues. First of all, I'm pleased to share with you that Senator Grassley has introduced a bill called the Emergency Support for Nursing Homes and Elder Justice Reform Act of 2020. And my colleague Bob Blancato of the Elder Justice Coalition briefed us on this just this morning. And here are some of the things that this bill would do: provide funding for PPE for nursing home residents and their healthcare workers, which is obviously critical; reauthorizing key provisions of the Elder Justice Act, and also providing support for the Alzheimer's Awareness to Prevent Elder Abuse Act. And then down there on the bottom, creation of strike teams to assist nursing homes during pandemics such as COVID-19. Moving to the public health law arena, our first speaker in this series was our, again, eminent colleague, Larry Gostin, who spoke about the issues of crisis standards of care. When we are experiencing conditions of scarcity, we need to move to crisis standards of care. Larry was involved in the writing of the Institute of Medicine Crisis Standards of Care, which I think are critically important. In my own state in New York, we did a gap analysis of state and city laws in 2008. And in New York, we have neither crisis standards of care nor a model emergency law. And I think that was detrimental to us. The New York State Bar Association Health Law Section Task Force has also recommended the adoption of uniform ethics triage guidelines for deciding who gets care. And at this point in time, we're also awaiting movement on that particular recommendation. The strength of the crisis standards of care is that it advances a systems framework and looks at all of the providers, all of the care recipients and communities as one single system. And so I'll leave you with this question, and that is, in the United States, is it your view that nursing homes were treated as part of a single system in this pandemic? So perhaps we'll hear from you later about that question. I'd like to spend my last few minutes on palliative care, which is a cross-cutting issue and really an ethical minimum in a situation such as the one we faced with COVID-19. In such crisis circumstances, every attempt must be made to offer pain management and comfort care to disaster victims. Here's a little bit more about palliative care. Palliative care is a right encompassed in the right to health. And in the United States, palliative care is an umbrella term that includes both hospice and non-hospice care. Our colleague Diane Meyer, who's one of the leading palliative care physicians in the United States, calls it a secret sauce, and it certainly has been a secret sauce during this pandemic. And we've heard many, many stories from healthcare workers on the ground who are providing palliative care in ICUs and emergency departments, as well as in the community. In New York, we have a statutory right to palliative care under 2 statutes that you see there in the public health law. But the exciting thing that I want to talk about is that we're moving beyond palliative medicine in the 4 walls of the hospital to integrated medical and social care and what I call building palliative environments. And that's, again, the nexus where palliative care sits. Supporting health care and the provision of health care, but also enabling the building of palliative environments. The 73rd World Health Assembly did adopt a resolution calling for the provision of palliative care and the protection of those with pre-existing health conditions, older persons, and others at risk. And consistent with the international frameworks and what we've seen done in the United States to date, although I have to confess that we're probably behind many other countries in the development of palliative care. But the crisis standards of care identify palliative care as a moral and ethical imperative. And for the very reason that I've mentioned, that when we are experiencing scarcity of resources, it is incumbent upon us as a society to provide pain management and comfort care to relieve suffering in the event that resources are not available. And as we've seen during the pandemic, many persons are dying. And unfortunately, we've also seen many persons dying alone. And part of the palliative care ethic is providing social and supportive care and distress counseling. The public health strategy for palliative care, which integrates much of what I've been talking about in the context of palliative care, bringing together public health and the provision of health care, has four main pillars. And this has been around since 2007. I talk about this a lot, and I think it's very relevant to some of the reforms we need to make in the United States in response to the COVID-19 experience. Those pillars are policy development, policy implementation, assuring access to essential medicines, and education and training. And our colleague, Dr. Tom Caprio, will talk more about the critical importance of generalist level palliative care education and training. But these four pillars are going to support the progressive realization of the right to health. A quick a snapshot here of the key recommendations of the New York State Bar Association Health Law section in its recently released COVID-19 report. So I'll highlight the mandatory vaccine recommendation, of course, after phase 3 trials and efficacy and safety have been established, and also with a personal medical exemption. We call for prioritizing healthcare workers in access to vaccines and testing. We also call in New York for the adoption of the Model State Emergency Health Powers Act as reviewed and revised, and adoption of non-discriminatory ethics triage guidelines. We have been operating during the pandemic in the absence of such guidelines, and in such circumstances, imposing an unacceptable moral burden upon clinicians who are in the position of having to make these decisions without having guidelines to rely on. And I've already mentioned, but will highlight again, the provision of palliative care as an ethical minimum when there are scarce resources. So I'll close with recommendations from the former CMS Administrator, Donald Berwick, who speaks about the moral determinants of health in a recent JAMA article. And he envisions very bold future directions here in the United States, and I think he's right on target. He calls for the United States to ratify the United Nations human rights agreements, codify healthcare as a human right, restore climate change to the policy agenda, prioritize criminal justice and immigration reforms, as well as hunger and homelessness policies, and restabilize U.S. democratic institutions. And as you will see, these are determinants of health outside of the healthcare sector. Other lessons learned that I will share and recommendations that I will make is we certainly need to invest in our public health systems to ensure the progressive realization of the right to health. We've certainly seen that during the pandemic. Invest in scientific research to inform evidence-based public policy planning. Strengthen social bonds, solidarity, and shared responsibility for our common home, in the words of Francis. and perhaps most importantly, strengthen social protections for all people to eliminate inequalities and reduce poverty and vulnerability across the lifespan. And of course, that demands elimination of all forms of racism and discrimination. Thank you very much, and I will now turn the program over to my colleague, Dr. Tom Caprio.
Thank you so much, Mary Beth. I appreciate you setting up the background here. For what I'll discuss is kind of the idea of lessons from the front lines. And as Heather had mentioned at the beginning, I'm Tom Caprio. I am a physician, a geriatrician, palliative care physician, hospice medical director. And in particular, I'm going to emphasize about the lessons learned that I'll broadly describe as being across the continuum of care, of long-term care settings. So home care, nursing home care, as well as assisted living communities and other such sort of congregate living areas. That's the space in which I sort of work in every day and have had to really see the day-to-day struggles that have occurred with the pandemic. So just by way of review is that, you know, it was the start of the new year, and then coming into February and March that we started learning about this new virus, the SARS-CoV-2, that causes the disease that we have referred to as COVID-19. And the reason I put this slide up here is that we have had a tremendous amount of enhanced understanding from the first few cases that were identified in the United States to where we are now in terms of the pandemic. And that has both been interesting from a scientific standpoint, but also a challenge from the standpoint of keeping on top of what the evolving recommendations were with regards to personal protective equipment and the transmissibility. And it's still even evolving now with various comments and new research that's coming out about how long the virus exists on certain surfaces, how much that's airborne, and so forth with it. But we have learned a tremendous amount from, I remember in the very early discussions of this pandemic that we were talking about covering your cough, washing your hands, and a lot of the interventions that we had used to stop the transmission of influenza and other viral illnesses. And then it quickly evolved to, no, you have to wear a mask. No, we need to have eye protection. We need to have gowns. We need to have personal protective equipment. And not only is it from an administrative and from a clinical standpoint, hard to sort of keep up with all of these kind of rapidly evolving recommendations, but imagine from the perspective of the frontline care workers within congregate living facilities and nursing homes that one minute they're saying, you know, wear the mask when you're going into this room to see this patient. The next minute now, policy has changed and we want to everyone wearing a mask all the time. We're closing down the cafeteria space that employees use and so forth. And so that became a real challenge, I think, across many different settings of being able to have a consistent messaging and trust that we knew what we were doing because so many of these recommendations were evolving. And if we look at this idea of vulnerability of who is being affected, Mary Beth set the stage very nicely for this, of sort of thinking about, this is the CMS data of showing the hospitalizations that were occurring in the older adult population. So these are Medicare beneficiaries. And you can see over on the left here, the comorbid conditions. So these are the underlying chronic health conditions that these folks that were being hospitalized with COVID-19 had experienced. And it is no surprise when we look at things like hypertension, hyperlipidemia, high cholesterol, chronic kidney disease. These were identified early on as significant risk factors for having not only a risk for the infection, but those that would have much more significant or serious illness after the infection. And it also converges with the risk factors that we know are disproportionately represented in racial and ethnic minority populations. And so again, sort of the perfect storm of understanding the vulnerability and the inherent risk that this older adult population was facing. The other thing I want to point out is if you look further down on the bar chart there is Alzheimer's disease and related dementias. Close to 40% of these individuals that were hospitalized for the COVID-19 infection had that as a comorbid condition. And so again, from a vulnerability standpoint and the challenges that brought apart, particularly with isolation in the inpatient settings, the disconnect with families, that these are the folks who were experiencing delirium and other very serious kind of conditions. This is the world that I talked about that I continue to live and work in right now, is that I was not involved in the direct inpatient care, the ICU. My colleagues, I give a tremendous credit of that we're working in the hospital, of being on the front line of taking care of those folks and having limited sort of resources from both a staffing and worrying about running out of ventilators and those sorts of things. I had a little bit of extra time to begin to sort of plan and think about what does this look like in terms of our patients that are being discharged from the hospital to the home setting. What does this look like in terms of clinical practice in the nursing home and patients that were getting sick that were residents of long-term care facilities or assisted living facilities? And I can tell you is that there's a lot of mixed emotions that were occurring upon these clinical sites of care very early on. The hospitals did not want to have all these patients coming in that were from nursing homes and assisted living that would start to fill up the beds and potentially not allow for the capacity for a surge of incoming patients. At the same time, many of these facilities were looking at the fact that they didn't want someone who had COVID-19 to potentially begin infecting more people at their facility. One nursing home administrator was quoted as saying, "We don't want them here. Get them all out. Get them discharged to the hospital as soon as they test positive for it." And then the hospitals, again, wanting to get these folks back as quickly as possible, decompress their bed situation. And so you can see this tension and this push and pull with it. But also from the home setting is that we were trying to maintain folks that were already diagnosed, but maybe not sick enough to be in the hospital to be able to be cared for at home, but monitored close enough so that we would be aware if they had a change in clinical status that required a hospital level of care, that we could quickly get them into the hospital. And so that's really kind of what we were dealing with, is this kind of relationship back and forth with the hospital and the discharge locations. This, again, going back to the Medicare beneficiaries, showing what the discharge status is from the hospitalization. And you can see almost 30% of these beneficiaries died from COVID-19 in the hospitalization, again, representing the sickest people with the infection that were going into the hospital. But more than a quarter of them were being then discharged to home. And then we can also see the skilled nursing facility and the home health programs. These are folks that were not just in the hospital for a day or two. 50% were in the hospital for between 1 to 7 days. And you can see 18%, 16% that were longer than a week, approaching 2 weeks period of time. So very significant prolonged hospitalization, which again, if you're thinking about in terms of bed capacity in the hospitals, raised some real concerns about if the capacity was there to meet any potential surge. So a lot of my focus had been on the home care services that we had in place. And home care, it was kind of both two priorities in our mind. One is that we already had a lot of home care patients that were receiving our care, and we had to continue the care as usual, particularly for those that are medically fragile and at risk for being hospitalized, because the last thing that a person who has chronic cardiac disease wants to do is end up with exacerbation of their condition back in the hospital where there's visitor restrictions and a high prevalence of the COVID-19. So we wanted to make sure that we were monitoring these folks who were not infected with COVID-19, maintaining their health status so that we could ensure that they weren't filling the hospital beds. At the same time, making sure they were accessing care, because we had seen this across our primary care environments that patients weren't seeking care. They didn't want to go to the hospital. The census in the emergency department went way down. If you weren't experiencing the COVID-19 infection, there really wasn't a reason. People were too scared to be going into the hospital with it. So that presented a challenge that we had to really do basic home care 101 to ensure that nursing visits and telemedicine visits and things were taking place so that we can maintain patients in their home. Those that were infected with the coronavirus and were suffering from the COVID-19 illness, the goal was, if they were not sick enough to be in the hospital, try to keep them home. And once those that were in the hospital were being discharged home, we wanted to continue their care. And we had a surge of patients that were referred from our hospital. We had probably between 50 to about 70 patients at any one time, but we've had over, from our largest academic hospital, over 500 COVID positive discharges to date. And we had to continue to care for them at home, which allowed us to leverage a lot of technology that we already had sort of in place, but needed to scale, like telehealth monitoring to see if there's a change in their clinical status. We needed to continue to monitor carefully those who had been discharged from the hospital to ensure that they weren't getting sicker and had to return to the hospital. I'm very pleased to say is that we actually only had, I think, of all of our patients, 2 that actually got re-hospitalized following the illness. But I can't emphasize enough the fact that folks that had the COVID infection that were in the hospital and discharged to home, these were very critically ill patients still at home that required a lot of ongoing support and care. And we also have a hospice program with the agency I work with, and so we were supporting end-of-life care. And we were seeing patients both that had end-of-life care because of other chronic conditions and cancer and heart failure and other things, but then also those that were faced with end-of-life care because of the coronavirus. This required us to really begin to pivot the entire way we worked, new staffing protocols, the personal protective equipment, and a lot of managing the anxiety, as you can imagine. For my nurses and the home care staff going into the home, they were on the front line every day, and they had no idea, and particularly until we started scaling up more testing capacity and things, about if the patient and family that they were seeing on their next home visit had potential risk factors or potentially even had the COVID infection. You can see over in the lower left-hand corner, this is kind of our new normal. So a lot of our meetings and a lot of our clinical encounters and a lot of my patient encounters now were exclusively over in terms of video telehealth and video conferencing. You can also see this cubicle kind of workspace that was at one of our main offices, which no longer was acceptable, too high of a risk for transmission. So we had to pivot a lot of our non-clinical staff to be working at home, as I know many different organizations had to do as well. My other area of practice is across the nursing homes and assisted living, both with the home care and the hospice programs and as a geriatrician. And I just kind of put up a collection of pictures and things here just to highlight a lot of what Mary Beth had already talked about in terms of the high mortality rate that really has traumatized the staff. We're working on, through our education center, on building a trauma-informed care kind of perspective for critical incident debriefing. Imagine if you were a nursing home staff member that you had 5 or 6 deaths in one night, in one shift overnight from COVID-19. This experience happened. We've had facilities in which somewhere between 50 to 60% of all the residents in the facility were infected. The shortages of the PPE. In the lower left-hand corner, you can see there where staff started using garbage bags and things to provide protection. The media coverage, certainly to some degree there was some sensationalization of it and those sorts of things. But imagine the fact that you are moving forward into this sort of care environment every day, working on the front line, and a lot of blame is being pointed towards staff causing the infection and spreading infection and those sorts of things, and trying to do the best job you can. A lot of times this has really taken a toll on the workforce and the staff and creating more shortages. And then not to mention the loneliness, the sense of isolation that occurred because most of these facilities, including the hospitals, limited visitors or completely shut down with it. And so these kind of window visits that had to occur. In the lower right-hand corner, this is very personal for me. That's my grandmother, who's in her late 90s, who was residing in assisted living facility at that point. And this is the means of communication. It was by phone and by window is the only way that we were able to make that connection because of these restrictions in place. As Mary Beth had talked about, palliative end-of-life care became even more challenging in these environments. Facilities that were closed started refusing having our hospice staff come in. Clergy and chaplains perform the last rites, the sacrament of the sick. That has very real implications with regards to the end-of-life care and the grief and bereavement of the families. The family visitation that I talked about, the workforce shortages, which delayed assessments of pain, of personal care, of being able to actually interface with the residents of these long-term care facilities. We had an example of one facility in which reporting for a shift. Half the workforce did not show up for that shift. Imagine the gaps in terms of staffing and care that occurred with it. And the real challenge is mediating sort of the discussions across with families and caregivers. If you have these visitor restrictions in place in the hospital, in the nursing home, the assisted living, it was a very big decision about where patients are being discharged to or to go in the hospital. The family would know that if they have a loved one in their home and sending them to the hospital, the visitor restrictions, they may not see that person through to the end of life. It raises a whole different metric. And as Mary Beth had talked about, this idea of primary palliative care. You know, we deputize our nurse practitioners and physician assistants and social workers and nurses that were having very meaningful conversations about what is the best care and what is the potential benefit versus the risks of hospitalization. What is desired in terms of the outcomes and the management of some of these very, very sick residents because of the infections. And so just to conclude my section here is that I think, you know, looking ahead, we have some sort of challenges and opportunities, and I'm continuing looking for the silver lining in what we have learned. I think this has underscored a tremendous need for, you know, the crisis standards of care, as Mary Beth had talked about, but emergency preparedness overall. And in thinking about that this long-term care is as a system, and Mary Beth has raised this question about the supports and resources, I think we began to realize in retrospect that it's not just about a hospital and healthcare system and what's affiliated in terms of the inpatient and outpatient services, but they are uniquely and intimately tied into the community, and they depend upon the success and the failures upon the long-term care settings and how the workforce is operating in those environments, including the protective equipment and their protocols in place. It's not an us and them. It's not about this is a for-profit versus a not-profit nursing home. This is owned by the health system or not. I think we underscore the idea of new system collaborations and new government collaborations with healthcare and long-term care settings as well. We prove the fact that we have the telehealth technology, but the real challenge is continuing to deploy it. I continue to encounter that with older adults in the home, that they don't have the technical literacy, or they don't have the equipment or the Wi-Fi to be able to do a televisit with a clinician. And so that becomes a continuing challenge, even though we have the technology that can do it, it's getting it to the right spot. And a lot of what we're focusing on now, I'm an academic geriatrician, is looking at from a research perspective to see what are the lessons learned and what can we do to plan ahead for the next surge or the next pandemic that may be occurring. So I want to thank you very much. I'm going to hand things over now to Jeff for the next part of the presentation.
All right. So my name is Jeff Kagan-Trenchard. Up until very recently, up until last week, I was the senior staff attorney for New York City Gay and Lesbian Anti-Violence Project. I had to resign because my partner works for Northwell Health and has been doing 12+ hour days since March. And we have 2 small children, and it is just not possible for me to maintain a full docket of casework, as well as, figure out where my kids are going to be going in the fall, among other situations. So up until very recently, the majority of my docket was representing LGBTQ and HIV-affected immigrants who are seeking asylum or other forms of humanitarian immigration relief. There are protections available in the Violence Against Women Act and for people who've been trafficked, victims of crimes, things like that. I also do a lot of work with the New Sanctuary Coalition. New Sanctuary Coalition runs a free legal clinic that is available for people who are not able to find an attorney. In the United States, you aren't assigned an attorney the way you are in a criminal matter if you're in deportation proceedings. So a great many people are forced to represent themselves pro se, so without an attorney, as they are facing the entire force of the Department of Homeland Security that is trying to throw them out of the country. New Sanctuary helps not only connect people to attorneys, but also help advocate for their rights pro se in immigration court. So Mary asked me to be a part of this panel. Some of my initial thoughts, like sort of my first wave, specifically had to do with home health aides, particularly in this like palliative space. A lot of the immigrant, undocumented, and now recent citizen and recent legal permanent resident folks I know work in these settings. And particularly for those who are undocumented, they are in such a precarious place with regards to what power their employers have over them, and therefore are in a place where they cannot really advocate for themselves or for their patients in terms of making sure that these sorts of standards are being met. It's one of these sort of like perfect storms, as we've kind of discussed, of systemic racism exacerbating or COVID exacerbating certain aspects of systemic racism, right? You have people who are undocumented and therefore terrified of their employer calling ICE and getting them arrested and having them thrown in jail, now forced to do a lot of the jobs that are deemed, of course, essential at this point, but they're even more subject to exploitation along a myriad of axes. The other sort of thought that occurred to me, like in this context, and something that has really, we're seeing a later effect of. So there was 2 years ago, the Trump administration put forward what's kind of known as the public charge rule, which makes it very, very difficult for a relatively narrow group of people to eventually normalize and get legal permanent resident status if their children or people in their household have ever gotten certain kinds of government benefits. It's actually a very narrow portion of the total immigrant and undocumented population, but the specter of fear that the Trump administration, through that, as well as aggressive ICE arrests, as well as ICE appearance in courthouse, as well as child separation and the creation of a literal concentration camp on our southern border, what the public charge rule did functionally, at least what I saw with my clients and my colleagues and my friends, is that even people who were not subject to the public charge rule were terrified of getting Medicare, Medicaid, engaging in hospital systems. There was this tremendous fear for the undocumented and the immigrant population that any interaction with a government-owned health service would result in some sort of detrimental thing happening to their immigration case. Now, that coupled with what I mentioned earlier about the inability for a lot of people to be able to access an attorney and actually find out what their options and rights were, has created this incredible climate of fear, particularly in New York City, where it has been the epicenter of these cases. So in terms of other, Mary Beth mentioned some of the other traumas that are indicative of some of the populations I've worked with, and the way that sort of as a comorbid incidence with COVID. I mean, first and foremost, because of what's been happening in the immigration detention setting, not only because of the horrendous human rights abuses that have been going on as long as there have been these settings, but the increasing number of them under the Trump administration. Then added on to that is the specter of COVID in these situations, and the Trump administration is now trying to make rules that would allow them to not release anyone if there was any sort of public health issue with regards to immigration, their immigration detention setting. Again, like this winds up creating an entire portion of our population that is reasonably terrified of ever engaging with any system that might wind up getting them thrown into jail where they're going to die of COVID. In addition to that, there's kind of this additional trauma of that I see for a lot of my clients who are asylum seekers. So they're by their nature people who've been sort of failed by a larger system, right? Like they've been failed by their government. That's why they're coming to the country. And to come to America and I can only imagine the sort of heartbreak and moral injury that they must be facing, thinking that they've left one situation only to run in, very out of the frying pan into the fire kind of feeling it must be. For them to imagine that America and to have a belief that America is a place where at the bare minimum their life matters, that there is some sort of concern for their existence, and then to have a government that seems so incredibly apathetic to the deaths of its own citizens, and then particularly viciously attacking those who are not citizens and living within the country. I can't even imagine the kind of trauma that exists within that culture, even before you get into anyone's individual life and the things that they've experienced or the things that they continue to experience in America. Another issue that I particularly see in my line of work is that the Department of Homeland Security is actively and aggressively trying to reopen the immigration system. So asylum interviews, which are, so when you arrive in the United States, if you don't cross through, if you aren't apprehended at the southern border and immediately sort of put into deportation proceedings, if you're in the United States, you come here on a tourist visa or a work visa, or you manage to not be apprehended when you cross the southern border, you can apply for asylum affirmatively. Because it is a human right under international and U.S. law to be able to apply for asylum. When you go through that process, the first step in that process is an asylum interview, and that interview is typically conducted in person in a very, very small room. Imagine sort of the worst job interview you could ever have to sit through, where you have to really discuss in graphic detail not only the nature of your trauma, but the nature of who you are and why you were attacked. So those interviews are now continuing. I have a pro bono case that I was supervising where a client went in for the interview on last Monday. The lawyer was given the option of either not being with the client in the room while they testified, or having to sign sort of the similar waivers that Trump is requiring people to sign at these rallies, where we are not responsible if you contract COVID because of the situation. And then the applicants are testifying through iPads that are placed in one office, and the asylum officer is in another office watching through the iPad. Now, this of course begs the question why we couldn't do the entire thing remotely. And I have to say that I truly do believe that it's because the kind of brutality that is being done in the immigration court system is completely intentional on the part of this administration. They are, I think, actively trying to exacerbate the amount of impact that COVID is having on these communities. And I think particularly they're trying to use immigration attorneys and my colleagues to do that. Immigration attorneys are an excellent vector if you would like to get as many undocumented and immigrant populations as sick as possible. All we do is talk, and a huge portion of our business takes place face-to-face, and there are portions of it that can't really exist without a one-on-one interaction. Imagine coaching someone to talk about, like, almost being killed or the brutal rape that they endured, and only being able to do that like over the clamshell as we're doing it now. It simply doesn't work. So because USCIS and the Department of Homeland Security are forcing attorneys and applicants to appear at these interviews, they are in effect trying to, I believe, trying to create as much exposure and as much terror in our lives as possible. I know that's a very dark thing to say. To end on somewhat of a brighter note, similar to what a lot of my colleagues have said, one thing I am grateful for that COVID is forcing us to have conversations around is the fact that COVID and other similar kinds of disease, the kinds of disasters that are going to be happening because of climate change are completely unconcerned with our immigration status or our citizenship or our bank account or our I mean, that's not to say that people who are poor are not more affected, but rich people can get it too. And my sincere hope is that the kind of response that has happened in the hospital system, as mentioned by some of the other speakers, and that I have a ringside seat for, as my partner works for Northwell. The kind of cooperation and collaboration and the kind of removal of old lines of fiefdom and just concentrations on capital and interest being focused on capital, those going away, I think, are, if there can be anything really positive coming out of this situation, it will be that. It will be a recognition that COVID is unconcerned. These sorts of things are unconcerned with whatever piece of paper authenticates you to live in a particular area. We are joined by our proximity in our community and our relationships with each other. And those boundaries and those connections are essential and important and relevant and in fact more meaningful than random accidents of birth of what it actually says on our passport. So while this is an incredibly dark time, I do have some hope that we're going to eventually come out of it with a really different, broader understanding of the necessity of truly caring for all of the people within our society and not making sort of arbitrary delineations around who does and does not deserve care. Thank you very much for the invitation and for being here and for spending time. I'm going to pass it now over to Chris. Delay slightly because I know we're all trying to dodge with muting and unmuting ourselves.
All right, thank you very much, Jeff. I'm Chris Comfort. I'm from the downstate area. I'm in New York City and run a system of a hospital that is involved in primarily palliative care experience, as well as a hospice that does work throughout the boroughs of New York City. I'm going to present to you today, I think, mostly a statistical look at the experience downstate, because I think that the statistics are important for us to try to understand in greater detail what the experience has been so far for the New York City area and how that translates into the experience both medically and socially for the rest of the country, as it is going to go through, it looks like, very similar experience as New York City went through. To let you know, I don't have any conflicts or associations that would cause me to have some difficulty with associations within the presentation. This is going to be a bit dry, but I think it's because it's important to understand a bit of the experience that we had and where we fit into the timeline, as well as the numbers related to COVID. As you know, COVID as an illness has really exponentially increased here in the United States since early March. I think that good recognition of COVID as an entity here in New York City began toward the end of March. This was preceded by the governor's call for all hospitals to double their capacity related to the care of patients. And we, although a post-acute resource for most institutions, did double our capacity to about 450 beds to care for patients, whether they were discharged from hospitals prematurely related to making space for COVID patients, or as we experienced having to care for COVID patients ourselves. It was fascinating to look at a timeline of COVID as well as COVID deaths and compare that to data that came from New York City related to the experience with the Spanish flu 100 years before. And in fact, for the first week and a half to 2 weeks of the experience here in New York City, the graphs of death look almost identical to the deaths that were seen in the early phases of the Spanish flu in 1918. Fascinating to see history really repeat itself over time. New York, as you know, was the epicenter of the illness. New York City clearly heavily hit by the illness. It was a very specific geographic area, actually, that was involved with COVID. In the early part of the disease, we found a progression of illness that began actually in Westchester County, just to the north of the city, migrating down relatively quickly into the area of the Bronx, where our hospital resides. In addition, simultaneously, areas of Queens had an initial institution of the illness that spread into Brooklyn, and both of those spreading, both from the south and the north, came into Manhattan. If you look at total cases of COVID within New York City, it's an amazing look at the movement of the illness through Queens down south into Brooklyn and then into Manhattan, and again from Westchester into the Bronx and then down to Manhattan. Surprisingly, if you look at the rates by borough, these are rates per 100,000 people. The Bronx had the highest rate at about 2,400. Staten Island actually at 2,200. Queens at about 1,900, and Brooklyn at about 1,500. And Manhattan, where I guess most people think major institutions fought the COVID battle, had only 1,000 per 100,000. If you look at the mortality by borough, the mortality in the Bronx up to now looks at about 3.3%, in Queens 2.8%, in Brooklyn 2.3%, and in Manhattan about 1.6%. Those of you who may be familiar with New York City realize that the lion's share of sophisticated tertiary care that occurs in the city occurs in Manhattan, and that the rest of the boroughs are serviced by either community-based hospitals or systems that are associated with Manhattan systems, or part of the city hospital system itself. The death rate in New York City looked about the same as in the United States itself, but the number of cases obviously were much higher in New York City. The caveat to that is I think we've just got the tip of the iceberg here, because if you look at cardiac arrest 911 calls here in New York City compared to last year, they were increased 4 to 5-fold. And cardiac arrest deaths were increased by the same number. It looks like, in fact, a number of the deaths that we were seeing related to COVID when it occurred in the home setting never made it into the medical system in the first place. And those obviously have not been counted in terms of deaths related to COVID because documentation of either positive testing for COVID or an opportunity to have a discussion of symptoms related to their illness never occurred. It's fascinating to look at the first experience that was published. This was in the New England Journal, based out of Weill Cornell, which is in Manhattan. They described their first 393 patients. The median age of those patients was 62 years old. It looked like the percentage of males was about 60%. And the race identification of Caucasian was about 37%. Clear associated conditions included obesity, diabetes, hypertension, chronic obstructive disease, asthma, and coronary disease. And the rate of intubation and care of those patients in the intensive care unit within the first 3 hours of their approach to the hospital was as high as 10%. This has some implications because the United States has the largest number of critical care beds per capita in the world at about 34 per 100,000 inhabitants. Germany's number 2 at 29 per 100,000 inhabitants. And here in this very high-tech type of medical system that we have here in New York City, with 7 medical schools sitting within a 10-mile radius of me. The initial reports from the Northwell Health System for the survival of patients was reported based on age group and looked at those patients who required mechanical ventilation, reporting an 18% death rate in the age group less than 65 and a 31% death rate for those patients who are greater than 65 years of age. This data was published in the first 2 to 3 weeks of the COVID experience. Subsequently, the New York Times reported data from Northwell that reported their mortality of patients treated with a ventilator at 88%. and that the mortality of patients between 18 and 65 years old who required a ventilator was 76%, and the mortality on a ventilator of someone over the age of 65 years old was 97%. That is a stunning, stunning figure, and led many of us to start looking at a question of dealing with an illness, with a pandemic, where the idea of futility was starting to be defined. That means that here was an illness that if you made it into the hospital, your chances of surviving this hospital stay, which I'll go over specifically at certain institutions, was in the 30% range, but if you were ill enough to reach the ICU and require ventilation, which was a significant number of patients, that in fact your mortality was quite high. Mortality by institution is fascinating to look at. If you look at systems, the Mount Sinai system as an example, as a whole, had a mortality of 17%. The majority of that came from their Manhattan facility in terms of data. If you took those facilities in other boroughs that were associated with the Sinai system, the mortality in Brooklyn at Mount Sinai, Brooklyn was 34%, and the mortality at Mount Sinai, Queens was 33%, double what it was for the system as a whole, representing a flagship New York City Manhattan institution. Within the city hospital system, there was tremendous variation in survival, with Bellevue, an institution down in Manhattan that is associated with the NYU system, showing a 22% mortality, but Coney Island Hospital, a Health and Hospitals Corporation institution that is nowhere near any established tertiary facility, showed a mortality of 41%. It was even more fascinating to look at the age-adjusted rates of death from COVID-19 from the city of New York, looking at race, so that the rate of death in the Hispanic Latino community was 22.8 out of 100,000 people. In the Black African American community, it was 19.8 per 100,000. While for the Caucasian community, it was 10.2% per 100,000 people, and the Asian community at about 8.4 per 100,000. Interestingly enough, if you looked at the progression of the illness as we experienced it, the Asian American community was really the first community to become affected. So that when the onset of COVID within Queens occurred, there was a tremendous rush on the hospital system, both in Queens and in Brooklyn, but that occurred almost exclusively from the Asian American community. More information related to race is fascinating to look here in New York City when the city published data related to their incidence and prevalence of situations such as hospitalized and known to have died COVID. The most recent data shows age-adjusted cases per 100,000 known to have died are 93 in the Black African American community, 74 in the Hispanic Latino community, and 45.2 in the white community. So it's clear that there have been huge differences in non-fatal hospitalized as well as known to have died that are related specifically to the race of the community. The explanation for that has been difficult to attribute, whether that is related to access to care, related to the way hospital systems in New York City have been organized, or it is related to other factors is very unclear. The other experience that we had here in New York City is related to nursing homes, and that is related to the governor's institution of an advisory about hospital discharges and Admissions to Nursing Homes, which was distributed on March 25th, where hospitals were told that discharge to nursing homes that could not be refused on the basis of a COVID status. Based on that, with discharges from acute hospitals into the nursing home system, there was over a 2-week period of time an exponential rise by about 150 to 200% of cases of COVID within the nursing homes and a commensurate number of deaths that were related to care in the nursing homes. There's been big concern that that process of discharge from the hospital into the nursing home, mandated by a governmental edict, was a cause of significant suffering and death related to nursing home cases. The Department of Health has recently released information related to an alternative explanation for the rise of cases within the nursing home, and that was their data looking at cases of COVID in nursing home workers that peaked about 23 days before the peak in cases in the nursing home. So the current explanation from the Department of Health here in New York State is that the rise of COVID and deaths related to COVID in the nursing home were not related to transfers from the hospital to the nursing home, but rather were related to the employees themselves, the nursing home staff themselves, being infected with COVID and coming into work at the nursing homes, spreading the disease throughout. There is no question that that is a huge issue in terms of where we saw COVID as a problem related to both seriousness of the illness as well as mortality. When you look at information here from New York State, about 50% of the mortalities that have occurred from COVID have occurred from patients who primarily originally resided in the nursing home prior to their hospitalization. If you look throughout the country, in Minnesota, it represents about 81% of the COVID deaths, Rhode Island about 78% of the COVID deaths, New Hampshire about 77% of the COVID deaths, and in a neighboring state, Connecticut, about 70% of the COVID deaths. The experience that we've had here at Calvary, now remember we're a post-acute facility, so after an acute facility treated a patient and that patient was to be discharged, these are patients who often were discharged directly out of the ICU, still oxygen dependent, many of these patients on non-rebreather masks or ventilatory support that's quite sophisticated, were transferred to our institution. We have cared for at the institution about 285 COVID patients. Their length of stay has been about 17 days, and our mortality for those patients is at 65%. So there is a two-step process in post-acute care. The first is the mortality related to the admission of the hospital, as I said, ranging about 20 to 35%. Now a post-acute care resource looking at a mortality after a week's stay in the hospital that is sitting at about 65%. Now we have treated probably about 2% of the COVID deaths in New York City, and those are post-acute care deaths. There's very little information about survival in the nursing home after transfer from the hospital. Remember that those hospitalization death rates are related to deaths that occur at the facility itself. They do not include post-acute deaths attributable to either an institution such as ourselves or an institution such as a transfer to the nursing home. Our experience with hospice was interesting. In fact, for the first 4 weeks of the COVID intrusion into New York City, we were the only hospital that was taking patients onto service. The other hospices were refusing to admit hospice patients from discharge from the hospital. These discharges to hospice were occurring after 3 or 4 day stays at the hospital. They were typically those individuals, they were typically elderly, where the decision for intubation was decided to be a futile event, and they were taken into the home setting under the service of hospice related to their poor prognosis. We've treated about 650 patients in the community with a COVID diagnosis after discharge from the hospital. The survival of those patients is about 30%. So a fascinating journey here in the downstate area that has raised some big questions about medical care for a pandemic event. The first is the disparity in survival that we're seeing that are clearly based on either a geographic distribution of the illness or associated with disparities related to race or access to medical care, which has profoundly influenced survival in this setting. The second is the confrontation of the fact that this pandemic may have introduced us to a palliative illness, that if an individual got sick enough to the point where they required hospitalization, certainly if they required transfer to the ICU, that they self-selected themselves based on survival statistics to be a population with an absolutely horrendous survival. I can tell you here in New York, movement to intubation became much less frequent once it was understood the poor prognosis of these patients, and these patients were supported with non-invasive ventilatory procedures because of understanding the abysmal prognosis of ventilation in the population greater than 65. That lesson has actually been learned in Florida, and the current state of affairs for the pandemic in Florida is that the move to ventilatory support of those patients is actually being dissuaded related to poor prognosis experience here in New York City. And the last was that I don't think we understand the consequences of this illness because I don't think we've followed post-acute data well enough to understand what this pandemic really meant in terms of care of the patient and survival. And I don't think we have any idea of the long-term consequences that we will see related to populations who survived COVID and were discharged into either the post-acute setting, institutionalized, or into the home setting related to their general condition. Thank you.
Thank you to all of our presenters. Thank you for that. And if anybody has any additional questions, please put them in the Q&A section at this time. Because you spoke a little bit about the challenges of having a continuously changing standard of care. And we started with this idea of crisis standards of care. And I know that at least in New York, they're not necessarily specifically provided anywhere in law, but there was this shift to a different crisis standard of care. And then as we learn more about the disease, the standard of care continued to change. And as Dr. Comfort pointed out, at first there was this idea and move toward ventilatory support, and then a move away from it. There was this idea that people should breathe better when they were being prone. And so that was something that we learned along the course of the disease. So do you have any thoughts or recommendations, or can you speak to how in the care setting you dealt with the challenges of that continuously changing standard of care?
Yeah, it's a great question. I think, in terms of the challenges with, there's always sort of new information and things, and Dr. Comfort brought that up, I think, very nicely, of the fact that there's a lot of areas that we still don't understand, about the infection and long-term consequences and those sorts of things. But I think that one of the most useful aspects was that what we have seen, particularly within our organization, is that we immediately sort of activated into emergency planning, where we had dedicated meetings and people that were in charge of looking at this kind of information, communications that were coming from our state health department, very early on. And that was really, I think, a key aspect of just staying on top of things. I give a tremendous respect to my colleagues, Dr. Comfort and others in the New York City area, because we're located upstate in Rochester, New York. We were about 7 to 10 days sort of behind, if you will, in terms of the pandemic and the surge of hospitalizations and things. And so we actually learned a lot by staying in touch with our colleagues that were downstate that were experiencing this before. And so we had several days sort of lead time to begin to sort of prepare and understand stuff about both from the clinical practice standpoint, but also from just the policy and procedures and protective equipment standpoint. And so that did, I think, take an advantage for us. And I think, and I'm hoping that other areas of the country are beginning to learn from sort of those lessons learned as well with it. The other aspect, and kind of this gets to the crisis standards of care that Mary Beth had talked about, is that we were very committed working with our ethics teams and working with many of the stakeholders within our whole health system to understand that we can't just make decisions on the fly in the emergency department when someone comes in about who's getting allocated a ventilator and those sorts of things. Is that we quickly began to draft and build upon a lot of our sort of protocols and things so that we would have some standards to work from, because we didn't want variation across clinician to clinician, shift to shift, or would there be a different sort of standard of care that is being provided at a hospital north of us versus south of us. And so I think that is really important that you look across, sort of the region and across health systems and not only have the most up-to-date information, but also to mobilize those folks that have the expertise in ethics and law and clinical medicine to come together to come up with standards of care.
Mary Beth, I have a question for you in terms of applying a potential crisis standard of care and just making sure that they're free of implicit bias that might be inherent or sometimes exist within the provision of medical care. Is there any way that you can think of to recommend how clinicians and other providers and ethicists can avoid the implicit bias?
Well, thank you for that question, Heather. And of course, that is an enormous challenge. And let me use, again, the example of New York and the work we did in the New York State Bar Association Health Law section in examining the need for uniform ethics triage guidelines, which would fall under that house of crisis standards of care. Back in 2015, the New York State Task Force on the Life and Law developed a set of ventilator guidelines that would address these issues of scarcity and who gets what care in crisis conditions. And regrettably, those standards were never adopted. In other parts of the country, states have adopted such standards. And again, just by way of example, there's been at least one enforcement action by the Federal Office of Civil Rights in terms of discrimination based upon age. So I think this is really a very difficult terrain to navigate, and it really behooves us to invest more time in studying these issues and developing non-discriminatory guidelines. And of course, beyond that, I think what's also critically important is provision of education and training. We spoke about generalist level or primary palliative care education. That is the kind of education we need to be providing to all healthcare professionals and healthcare workers, a system-wide approach such as what Chris Comfort has at Calvary. So I hope those thoughts are helpful.
Thank you. Yes, they're very helpful. And for Jeff, we've spoken a lot about the healthcare system and the provision of care specifically, but somebody had a question with regard to how they might help outside of the healthcare care field. And I know that this pandemic has not only affected the physical health of human beings in this vast city of ours, but it's also emotionally detrimental. There's loneliness and social isolation that's been mentioned, and the PTSD of our providers that Dr. Caprio talked about as well. There's been an increase in intimate partner violence that we've seen. There's mass unemployment and starvation, there's an uptick in suicide. So how might we address some of those issues? I know that was a very loaded question and a lot to deal with, but you can handle it, Jeff. Thank you.
It's funny enough. I have a product right here for you. It's a monorail. It's no. No, I think these are, yeah, I think it was Representative Ocasio-Cortez had a great line about how really like this is just poured, it's like poured gasoline on all of these existing fires. I mean, so I do a lot of organizing with attorneys and with non-attorneys around like, or I was prior to COVID. I can't really do a lot of town halls these days, but I still try and organize a bit. But sort of the main things that I would recommend to people when they were thinking about wanting to support the immigrants' rights movement, or just people who up until this point didn't really think of themselves as activists and didn't really think of themselves as people who would engage in the world in that way, are now really drawn to it, which I think is another one of those like kind of, when life gives you lemons, you sometimes paint that lemon gold, like a somewhat silver lining from it. And the main things that I always tell people when they're looking to get involved along any axis, there's on all fronts, everyone is suffering tremendously. I think that first and foremost, looking at the nouns of what you have and the verbs of what you like to do. So thinking about the nouns of what you have. So literally writing down on a list the kinds of resources that you have access to because of who you are, not just economic resources, but professional resources and connections, the kinds of supports that you can give, depending on where you are geographically. Some places are not nearly as social isolating the way that we are in New York. So like, being able to provide childcare for someone is a pretty incredible thing if they are engaging in some sort of direct service. Even, just keeping up with people and supporting and being like a person who can just hear the kinds of stories that people are going through, right? So you want to make a list of nouns of things that you have, things that you are, things that you have access to. And then you also should make a list of verbs, which are things that you like to do. I'm going to be spending the remainder of my professional career cleaning up the last 4 years. Like that's, like the ball will not be moved forward in my professional life. Like my professional life, the next like 50 or so years of it is going to be digging out of the hole the last 4 years have put us in. And that's everybody. I think that across the board, we're going to have to make up for so much time, for so much that we've lost in a very quick period. So thinking about what are the things you like to do and that you can continue to do to engage yourself and not burn out, because it's essential that you develop a habit of service and a habit of help and a habit of community engagement. So if you're a talky person, like think of the ways that you can be talking to people. If you are not a talking person, right? Like think about the ways that you can be researching, that you can be supporting, that you can be gathering data, you can be aggregating data, you can be signal boosting, ways that you can be like materially supporting folks, ways that you can help with those material support. So I think that in trying to address all of those myriads of problems, I think it really comes down to each individual person thinking about what their capacities are and what their abilities are, and then just finding the people already doing the work. I absolutely assure you, on all of the things that you mentioned, from intimate partner violence to suicide, to food scarcity, to homelessness, all of these, there have been people grinding away at these issues for decades, if not centuries. And if you are moved in this moment to start lending a hand and helping, I think that like now, like there has never been a better time. It's just about thinking about what you're going to be able to do sustainably, because the work is going to be continuing for, hopefully my kids will be seeing like the benefits of it,
Thank you. And Dr. Comfort, I have a question just to circle back to you, which is a different sort of back to your remarks with regard to the timing of the palliative care discussions. Now, in the acute care settings, people were coming in very ill, and so it wasn't necessarily, but we didn't know what the trajectory of disease was going to be at the very beginning. Do you think that those discussions should have been happening in the emergency rooms immediately when patients were able to have those discussions so that they could have a plan of care in place just in case they did not yet?
I think what we're learning is that when you've got an illness, that even with individuals who have comorbid conditions, causes deterioration so quickly. The situation was that most individuals, if they were going to go on a ventilator, had that occurrence in the first 6 to 12 hours of their hospital stay. This episode, this illness has called into question much of palliative care. And the reason it has is that it has caused a bit of a problem with the typical way that we've done our work, because we have always done our work hands-on, intimate, and directly involving both patients and their families in decisions. This has put us into a situation where there has been personal protective equipment between us and who we're caring for, and a telephone line between us and families, with families unable to meaningfully participate in much of what was going on during the stay and the care of the patient. I'll tell you our experience at Weill Cornell and Columbia, part of the Presbyterian system, is that we co-managed a hospice unit with them. It was a hospice/palliative unit, but that unit was a unit where essentially patients went to die. They were identified as poor prognosis. They were determined not to be a part of the acute care system anymore. And both of the institutions set up 15-bed units where patients with poor prognosis were sequestered from the rest of the patient population and forgivingly moved to a place where it was quieter and where there was the opportunity for care of those patients. But few, if any, of those patients had cognitive capacity to have discussions. And families were very, very far away in the physical location and in their ability to observe or even understand what was happening with a loved one. This is a real challenge because the type of palliative care that we typically give is not a acute rush kind of a care. It usually is spent over sessions, periods of time with lots of participation of patients and families. This pandemic did not give us the opportunity to do any of that. I think it's probably going to cause us to rethink what does it look like to provide palliative services to individuals who are severely ill, because it strained all resources related to palliative services for every institution and put us in a position where we really could not do traditionally what we have done in the past related to the provision of those services.
Mary Beth, you wanted to add something?
Yes, I'd like to make a closing comment here. And Chris, I appreciate your comments. And of course, we've worked together for some time and also with Dr. Caprio about models of palliative care. And Chris, you yourself have spoken about the heterogeneity in palliative care. So I think I'd like to close on the note that we are seeing a shift in palliative care models from this consult acute care model to a system-wide palliative care model. So I'll use the nursing homes as an example. I think if many of the nursing homes had instituted system-wide palliative care with education and training for all their professionals and healthcare workers, perhaps, again, as Dr. Comfort and Dr. Caprio have said, the jury is still out, but perhaps we would have been in at least a slightly stronger position to deal with this kind of pandemic. So thank you very much, Heather.
Thank you, and thank you to all our presenters. We're a little over time now, but I thank you for everyone who participated, and I thank you to our sponsors again and everyone who attended today. And I hope you all have a good evening. Thank you.